Hello and welcome back. My name is Erik Schabert. I am a doctor of osteopathic medicine with more than a decade's experience in family medicine and osteopathic manipulative medicine. And today I want to talk about heart disease. In medicine, we call this ASCVD or atherosclerotic vascular disease, and it remains the number one cause of death in the United States and a major cause of healthcare expenditures. In 2023, there were 680,981 deaths attributed to heart disease and another 162,639 deaths from strokes. If you take into account that less than half of all heart attacks and strokes are fatal, the incidence of these annually is just staggering. Now, I think with the tools we have available today, we ought to be able to prevent the majority of these events. So let's talk a little bit more about the kind of knowledge you're going to need to avoid these events, especially because these still happen way too early in life with high degree of frequency. Over 50% of men and 33% of women will have their first heart attack or stroke before age 65. That's too young. We can do better. All right, so let me tell you a little bit of a story why this topic is very personal to me. In 2017, my father suffered a stroke, and even though he made it to the hospital with minimal recorded deficits, and my parents identified very quickly that he was indeed having a stroke, and the hospital he went to was a stroke center and specialized in stroke care. Despite all of this, he ended up losing most of the function on the left side of his body. And I have seen him suffer now for 8 years because this happened to him. So I am hoping that by disseminating a little bit more of this information, I can help other families not go through what we've gone through. So we are getting progressively better at treating heart attacks and strokes in the United States. And we have seen the incidence and the frequency with which these events are fatal go down over the past decade. But again, this remains the number one cause of death in the country. And I do believe most of these events are preventable. Okay, so this is a disease that doesn't happen overnight. It's not as though your cholesterol and blood pressure elevate and then a month later you have a heart attack. This is a disease process that occurs over decades. And we can very frequently, in individuals who have heart attacks in their 60s, we can see evidence of atherosclerotic heart disease as early as their 20s. So this is something that we can detect early. It is something that we can intervene early in the chain on. And the earlier we intervene, the better our chances of preventing a fatal or disabling event. All right, so let's talk about what causes ASCVD, because I think we have a pretty good handle on what the pathology is that causes heart attacks and strokes to eventually catch up with people. And it really relates to a combination of three processes: elevated blood pressure, elevated lipids in the blood, and poor blood sugar control. And it's important that we understand the mechanism by which each of these things causes a progression to a heart attack or stroke. In the case of high blood pressure, the elevated blood pressure actually increases the permeability, that is, the ability to penetrate the lining of our blood vessels. And the base pathology is the deposition of cholesterol fats inside our artery walls. Elevating blood pressure allows cholesterol to more readily penetrate. In the case of elevated blood sugars, there isn't actually direct damage. We used to think there was very much elevated inflammation from the insulin resistance and elevated blood sugars, and that this would result in damage to arterial walls. Turns out that's not true. The best evidence we have today suggests that diabetes causes damage to the blood vessels through elevating triglycerides, a form of cholesterol in the blood. And the final of the metabolic factors that leads to this progression is hyperlipidemia, elevated serum cholesterol. And it's not quite the cholesterol itself that causes the issue and leads to the deposition of fat inside the arterial walls, the formation of plaques that eventually rupture and lead to heart attacks. It's a little bit more complex than that, and we're going to get into it shortly. The last thing I do want to talk about that is very important is smoking. Smoking causes direct oxidative damage to blood vessel walls, making them more permeable, and therefore it leads to very accelerated atherosclerosis. Please don't smoke, folks. It does catch up with you. All right. So we talked about lipid deposition inside arterial walls, that is fat deposition inside the walls of our arteries, as being the primary pathology that leads to heart attacks and strokes, and that is absolutely the case. What we need to talk about is what factors lead to that process. And it's an understanding that's changed a lot over the past couple of decades. When I started training in the early 2000s, we very much thought that it was all about cholesterol levels in the blood. And I was trained on elevated LDLs and how those were elevated LDL, elevated triglycerides were bad. Elevated HDL could be good. So you had good cholesterol, bad cholesterol. That's really not how it works. And the confusion, particularly surrounded HDL, I think has led to a lot of problems. We very much had a consciousness throughout a lot of my time in medicine that if you had a high HDL, that was protective and it could offset elevated triglycerides and LDL. And if you had a relatively high HDL, as opposed to the other types of cholesterol had, that you were going to be protected, you were safe, we didn't necessarily need to treat. This is an absolute misnomer. We need to get rid of that idea, and we need to look at things completely differently if we're going to get the kind of handle on cholesterol that will allow us to prevent heart attacks and strokes at the rate I think we can. So, as it turns out, the entire game is something called ApoB. ApoB is an apolipoprotein. And so to understand kind of what it is and how it's affecting this entire process, we need to go a little bit more in depth on what cholesterol is and why our body transports it and produces it the way we do. We very much need cholesterol. We need fats. It's a component of most of our cells. And our body needs the capability to transport it everywhere in the body. Well, since fats can't dissolve in blood, they can't dissolve in our serum, the only way to get them somewhere is with a transporter protein. That's what lipoproteins are. That's what LDL is. That's what HDL is. That's what VLDL is. And that's what ApoB is. And basically, these are proteins that we wrap around the cholesterol, wrap around the fat, so that we can transport it to where it needs to go. The problem becomes when ApoB counts get high. And it's important to understand the way ApoB works. ApoB is a protein that wraps around every particle of LDL and VLDL. Triglycerides are what are transported by VLDL. So VLDL is just a transport protein for triglycerides, which is a type of cholesterol. LDL transports some of the more common non-sugar related forms of cholesterol. A triglyceride is a type of cholesterol where sugar is bound to fat and wrapped up in a VLDL, transported away. ApoB wraps LDL and VLDL, and it's important to understand that there is one molecule or one molecule of ApoB on each LDL and VLDL particle. And so one of the things that has confused physicians and confused a lot of researchers is that we had this consciousness that LDL levels could be very predictive of heart attack and stroke risk, and that as long as LDL levels were hitting targets, that we weren't going to see adverse events. Well, data began emerging in the early 2020s that this was not accurate, and that LDL could be elevated and risk could be low. LDL could be in the upper third or so of the normal range, and we were still seeing events in individuals that seemed to be the target with normal triglyceride levels and LDL levels that weren't particularly high, and sometimes even with very high HDL levels. And we did not understand why. Well, as it turns out, this is because there are a lot of situations where ApoB and LDL levels don't correlate very well. Because when the LDL levels are small, LDL cholesterol will measure as not particularly high, and yet ApoB will be elevated. ApoB is the game. If ApoB is high, cardiovascular risk is going to be elevated. If ApoB is low, cardiovascular risk is going to be low. We have found that this tracks very consistently. So these are the numbers we need to look at. Unfortunately, ApoB is not on a standard cholesterol profile. The standard cholesterol profile is only measuring the amount of cholesterol in each of these different kinds of transport proteins. So we get the amount of cholesterol in LDL, the amount in VLDL, and the amount in HDL. This doesn't necessarily correlate with the absolute risk of heart attack and stroke. So what we need to be doing is measuring ApoB and making sure that that is controlled, because that is the mechanism by which ASCVD progresses. Basically, what we see is when ApoB levels are elevated, the ApoB actually allows LDL and VLDL particles to crash into that arterial wall, penetrate it, and deposit cholesterol inside the arterial wall. We get plaque formation. The plaques can become unstable. When they rupture, a clot forms over the top of them, and that is what is going to create your heart attack or stroke. So there is a number that does somewhat track with ApoB levels, and that is non-HDL. So if you take your total cholesterol and subtract your HDL, that number is going to be fairly close to ApoB levels in somewhere between 75 and 90% of the population. But there is still going to be a chunk of the population where those two numbers do separate. So ideally, we should be measuring ApoB and treating it to target. An extra nuance, there is another lipoprotein called Lp(a) that we cannot affect with any interventions that we have so far. It is linked exclusively to genetics, and when it's elevated, it always leads to an increased risk. As such, recommendations from the American Heart Association, and certainly from me, are that everyone have an Lp(a) checked sometime in their life, ideally as early as possible. I would suggest early 20s. If Lp(a) is elevated, the action to take is to aggressively treat ApoB and triglycerides to keep those low in order to manage all the risk that we can manage, since that Lp(a) number is not something that we can appreciably affect. All right, so let's talk about how we get ApoB down if it's too high, and let's talk about what too high is. So a ApoB level of 100 is about equivalent to an LDL of 130. Almost all of the recommendations we have is that we treat if LDL is in excess of 130 or total cholesterol is about 200. I think, the recommendation should be to intervene with medications if ApoB is above 100. And treatment target is going to depend on exactly what our treatment goal is. And that depends on what other risk factors are present. If you are somebody who only has an elevated cholesterol, maybe with a slight family history, LP(a) is normal, there's no diabetes, there's no prior evidence of heart disease or atherosclerosis, you don't have known peripheral vascular disease, you don't have known kidney disease, any other cardiovascular risk elevators, then it would be reasonable simply to treat to an ApoB of 80. Now, if you have, say, diabetes, or you have some known peripheral vascular disease, some mild kidney dysfunction, then I think a better ApoB target would be 70, to try and treat below 70 to get risk down as much as possible. If you have known cardiovascular disease, you have known arterial atherosclerosis of the coronary arteries, you've had a prior heart attack, you've had a prior stroke, particularly if that's combined with diabetes, then treating below 60 is going to be your goal. So if you're talking about how we lower ApoB, there are several things we can do from a lifestyle perspective that can lower apoprotein B. And the main things that we're going to look at is reduction of saturated fat intake and reduction of consumption of processed carbohydrates. So we're talking about, when I'm talking about carbohydrates, we're talking about sugar, we're talking about high fructose corn syrup, we're talking about white potatoes, white rice, white bread, things like that. And if you can reduce that consumption substantially, you can reduce triglycerides and along with it, ApoB. If you can reduce your saturated fat intake, you will reduce ApoB. Beyond that, we are talking about medications, and we do have a lot of tools now, much more so than we've had at any time in the past. And I really think that as long as we can make the available medications somewhat affordable, that there is no reason for anyone to be walking around with a protein B level that is higher than ideal. So let's talk about some of these different medications. First off, we have a class of medications that I think everybody is going to be aware of, and those are the statin medications. We're talking about Lipitor/atorvastatin, Zocor/simvastatin, Pravachol/pravastatin, and even Livalo /pitavastatin, and Crestor/rosuvastatin. Each of these medications is a little bit different in how they're metabolized, and that avenue of metabolism can change who tolerates them and who doesn't. From a tolerability perspective, the big thing we're looking for is muscle and joint pains that come on suddenly, and elevations in liver enzymes. Absent those, we can treat with a low to medium dosage, with or without another medication called ezetimibe. And this will inhibit cholesterol synthesis, and also through that process will inhibit the synthesis of apolipoprotein B. These are effective at lowering ApoB and will definitely decrease cardiovascular risk. The next class of medications are injectable biological medications called PCSK9 inhibitors. These are a relatively new advent. They've only been around for about a decade or so now. They're extremely effective and very well tolerated in my experience. The only downside to them is they are somewhat expensive. We have long and short duration PCSK9 inhibitors out there now with varying intervals that they need to be injected. They are very effective at lowering ApoB and serum cholesterol, and they are very effective at preventing adverse cardiovascular events. They can be combined with statins in individuals who need very low ApoB target goals met. They can also be combined with ezetimibe. Additionally, we have another medication called bempedoic acid. Bempedoic acid works on the same pathway as statins do, but it intervenes at a different point in that pathway. It also has the advantage of not passing into the brain at all, unlike statins. And therefore, we have zero concern about lowering fat levels in the brain and potentially increasing dementia risk, even though the data now shows that statins really don't seem to impact cognition at all when we study them long term. But the bempedoic acid, extremely effective at lowering ApoB, and also can be combined with ezetimibe. The two of them together will almost always get even somebody with the highest cholesterol numbers down below an ApoB of 60. All right, so that's covering a lot of our treatment options that are there. Additionally, we do have some drugs that specifically treat triglycerides for individuals who have persistently high triglycerides, even on drugs like bempedoic acid, statins, and PCSK9 inhibitors. One of my favorites, there is a drug called Vascepa that is a form of omega-3 fatty acid, but it is a prescription grade product, and it contains only the portion of omega-3 that is effective in lowering triglycerides, and that is EPA. So it's a pure EPA drug. It's nicely targeted, very well tolerated in my experience, and quite effective for lowering triglycerides and through that ApoB. We also have some drugs called fenofibrates. They're effective in lowering triglycerides, but they may not have as much of an effect on ApoB as we like. I've kind of put those on the back shelf for now in preference of other agents. One other thing I would like to mention when it comes to lifestyle modification, triglycerides are easily the most effectively addressed with lifestyle of all the types of cholesterol and lipoproteins out there. So it's kind of difficult to get ApoB down with pure dietary interventions unless your triglycerides are very high and your carbohydrate intake is what's driving those elevated triglycerides. If it is, by removing the simple carbohydrates from your diet and adding fiber, you can impact ApoB pretty significantly. All right, I know this was a lot of information, but I hope this was helpful and that this becomes something that you can have a discussion with your physician about. Get a cholesterol panel so you get your triglyceride number, you get your non-HDL number, and get a separate test for ApoB. It is a separate lab test. It's not an expensive one, but you frequently are going to have to request specifically to have your physician tested. And they may need to do a little homework so that they can figure out what the appropriate target for you is on ApoB. But again, I hope this is helpful. Please do like, subscribe, and share this video if you found it helpful. And I'll see you next time.